Good morning, good afternoon, and good evening. Welcome to the Symposium Global State of Micronutrients, Estimates, Uncertainties, and Addressing Data Gaps. The objective of this session is to provide an overview of the global burden of micronutrient deficiencies, highlighting uncertainties in prevalence estimates, persistent gaps in data and knowledge, and ways to address these gaps. My name is Rafael Flores Ayala, and I work at the Division of Nutrition, Physical Activity, and Obesity at the U.S. Centers for Disease Control and Prevention in Atlanta, Georgia, USA. Our first speaker is Dr. Lisa Rogers from the Department of Nutrition and Food Safety from the World Health Organization in Geneva, Switzerland. She will present the WHO estimates of global and regional anemia and micronutrient status. Then, Dr. Ashkan Afshin from the Institute of Health Metrics and Evaluation at the University of Washington in Seattle will discuss the micronutrient deficiency within the global burden of disease study. He will be followed by Dr. Sonia Hess from the Institute for Global Nutrition at the University of California in Davis, and she will present the challenges of estimating the prevalence of micronutrient deficiencies and related global burden of disease within the GBD study. And the final presentation will be given by Dr. Kenneth Brown from the Institute for Global Nutrition at the University of California, Davis, and he will discuss future needs and challenges for generating better data on micronutrient status. After we are finished with the presentation, we will move into a group discussion. Now, I welcome Dr. Lisa Rogers.
Hi, everyone. Thank you very much for having the honor to serve on such a great panel of speakers. It's really an honor to be here. And I wanted to thank the organizers for inviting WHO to participate in this symposium and this session to present on the WHO estimates for anemia and micronutrient deficiencies. So accurate and timely data are really thought to be quite essential for countries to be able to achieve the Sustainable Development Goals and the targets and goals for universal health coverage, health emergencies, and healthier populations. And as a steward and custodian for monitoring progress towards some of the health-related Sustainable Development Goals, one of WHO's core functions is to monitor the health situation and assess health trends globally. WHO also needs good quality data in order to ensure performance and improve program decisions, and also to increase accountability. With regard to vitamin and mineral status, WHO maintains the Vitamin and Mineral Nutrition Information System, also known as VMNIS. And this is a collection of tools and resources to help users in the assessment of micronutrient status. And the micronutrients database is just one of those tools in the system that collects and summarizes the population-based data on micronutrient status. Then WHO, or some of our partners out there, they use this data to provide the periodic assessments of the magnitude of micronutrient deficiencies. And these estimates are also then used to track progress towards some of these global goals. And there are also other tools that are available in the VMIS for monitoring the impact of different strategies that are being used to prevent micronutrient malnutrition. So WHO has been publishing estimates of the prevalence of anemia in various population groups since at least the early 1980s. And there's also been various methods for developing these estimates. They've been evolving over time, and they will certainly continue to evolve as we learn more about the determinants of anemia, as well as the statistical approaches and how they become more sophisticated over time. As of 2011, we've been using the Bayesian hierarchical mixture model, in which estimates are made for each country year. And these are informed by the data for that country year itself, if available, and also by data from other years in the same country and in other countries, especially those in the same region, with data from similar periods of time. These estimates are also informed by covariates that help predict hemoglobin concentrations, as I will show in the next slide. And our model also includes a variance term that accounts for the unobserved design factors, such as sample design, season, method of hemoglobin measurement. And these lead to additional variability in the data beyond what is expected just because of sample size. And finally, the model accounts for different, accounts for the fact that we have some subnational data and also data that doesn't always precisely cover the age ranges that we have of interest. And so these tend to have some larger variations than what we would expect for surveys that were nationally representative or those that did cover the particular age ranges that we are interested in. So these estimates have been restricted to children from 6 to 59 months of age and also women of reproductive age by pregnancy status. The data sources included the most recently nationally representative survey, if that was available. And if no nationally representative survey was available, then a survey representative of at least the first admin level in that country was used if there is at least 3 of these units represented. And for countries with populations living at above 1,000 meters, we used hemoglobin data that's been adjusted for elevation using the CDC formula. And then we also used data that were adjusted for smoking status if available. In our model, we also used covariates that help predict hemoglobin concentrations, and these differed by the population group. For women, these were maternal education, proportion of the population in urban areas, mean latitude, and the prevalence of sickle cell disorders and thalassemias, and mean body mass index. And then for children, it was mean weight for age z-score. The complete distributions of blood hemoglobin concentrations were estimated for each country year for pregnant women, non-pregnant women, and children. This then allowed us to calculate the relevant summary statistics, such as the population mean and the prevalence of total and severe anemia for each country year using the current WHO cutoffs. And what we see here in this first graph for pregnant women is a projected prevalence of total anemia, so that's hemoglobin less than 110 grams per liter in pregnant women, as well as for severe anemia, so less than 70 grams per liter in pregnant women for all years between 1990 and 2016. So at the far left, what you see is a 43% prevalence of anemia in pregnant women, and that's total prevalence in the top line for 1990, and then a predicted 40% prevalence in 2016. So we don't see much progress in total anemia for pregnant women. And then bottom line is for severe anemia. And what we see is a prevalence of about 2.5% that was predicted for 1990, and then 1.0% for 2016. And then in this next graph, we see the data for women of reproductive age. So this is non-pregnant women and pregnant women combined. And again, on the top line, you'll see the data for total anemia, where it started at 40% predicted for 1990, going down to 33% predicted for 2016. And for severe anemia, we predicted the estimate of 2.2% for severe anemia in 1990 and reducing to 1.4% in 2016. And in this last graph, we see data for children 6 to 59 months of age, again, following the same pattern. On the left, you'll see the top line, 51% estimate for 1990, reducing down to 42% in 2016, and for severe anemia, starting at 4.6% in 1990, reducing to 1.3% in 2016. Now, all these estimates are published in the WHO World Health Observatory website, where you can grab a table or a map of all the data. What I'm showing you here is the data for the prevalence of anemia in women of reproductive age. So it's a global map, and the shading of colors reflects the darker the color, the higher the prevalence of anemia. And if you were to hover over one of the regions, you can have a pull-out, what's called a tooltip or a box that shows the prevalence for that region. So here we see Africa in 2016 had an estimate of 39%. And then you even zoom in a little bit more over a country, and you can see the country data as well. And you can have the estimate for that particular country. And then the estimates for women of reproductive age are also being used for the WHO Global Target Tracking Tool in order to track the second global target, which is a 50% reduction in the prevalence of anemia in women by the year 2025. And what you see in yellow on the left is the baseline data for the year 2012, where we're comparing it to. And on the far right, you see in green the prevalence needed to get to 2025 in order to reach the target, and what the annual rate of reduction is needed in order to reach that. And then in the middle, you'll see the current trends. So if you look at the graph and you see the solid blue line, that's the model-based estimate. And then you see the dotted blue line, and that's the projected estimate with the current trends. And then the dotted green line is what is projected using the what is needed to get to reach the target. And then you can also do what if scenarios, which follows the orange line in the middle there. And then I just wanted to update you on the next round of estimates that we're currently working on and some of the factors we're exploring to try and improve the model. So we plan to maintain the Bayesian hierarchical mixture model and focus on children 6 to 59 months of age and women reproductive age. But we are exploring the inclusion of adolescent girls in our data set, and also looking at some additional covariates like the use of capillary versus venous blood, use of HemoQ versus automated cell counter, factoring in sickle cell thalassemias and glucose 6-phosphate deficiency, looking at malaria and other infectious disease incidents, and then also trying to include some dietary factors. And probably most of you know that the prevalence of anemia in women has now become an SDG indicator. So we're hopeful that we can do these updates of anemia estimates on a more regular basis going forward. And I just want to mention that we also estimated the trends in vitamin A deficiency for children 6 to 59 months of age in low and middle income countries for the years 1991 to 2013. And here we used serum retinol, as at the time it was the most commonly used biomarker for assessing subclinical vitamin A deficiency. The statistical model used was similar to that for anemia, which uses all the available data to make estimates for each country year. And the estimates were also informed by different covariates that might help predict the vitamin A deficiency at the population level, including the national income, maternal education, the proportion of the population living in urban areas, mean weight for age Z-score, and an aggregate metric for availability of calories in animal source foods. And we used a similar variance term that accounted for unobserved design factors as with anemia. And these estimates predicted a 39% prevalence of vitamin A deficiency for children in 1991. And this decreased to about 33% in the year 2000, and then again to 29% in the year 2013. These estimates suggest that vitamin A deficiency remains highest in South Asia and sub-Saharan Africa, as indicated in the red in that map there. And our results are looking like there's very little change during the past two decades within these regions. However, we have to put a qualifier here that we also have very limited data, and some of these figures are quite uncertain due to that data limitation. And then here's some work that we've done in collaboration with many fantastic colleagues from CDC, Nutrition International, FFI, for a technical consultation on folate status in women and neural tube defect prevention. And this was convened by the Micronutrient Forum. We again used the data from the WHO Micronutrients database that was supplemented by a review of the literature for published data on the folate status of women of reproductive age. And what we found were 45 surveys that were conducted in 39 countries between the years 2000 and 2014, using a variety of different assays and methods. And because of these large differences in results among the different types of folate assays, it's been an important focus in the last couple of decades to try and understand these differences and also to relate them to the cutoffs that are being used for a variety of purposes, and thinking about how these cutoffs might need to be adjusted when using these different types of assays. Ooh, I think I popped too far. Okay. So we again used we aim to systematically try to consider all these different types of assays. And just for simplicity, what we did is that we really focused just on folate insufficiency, that was defined as a risk of neural tube defects, and on folate deficiency, defined as a risk of megablastic anemia for this exercise. So because there's so much limited time here, I'm just going to really highly oversimplify things and say that what we did is we looked at how samples were collected and stored. We looked at the assays that were used to assess the folate concentrations. We looked at data from the different laboratory proficiency testing programs. And we looked at some of the cutoffs that were used within the survey to define deficiency or insufficiency. And what we did is we categorized the survey prevalence data as either likely underestimated, likely correct, likely overestimated, or not enough information to interpret. And what you can see in this graph here is a list of the surveys on the y-axis by income category, with E4 being the highest and E1 being the lowest, and whether they assessed red blood cell folate in black bars or serum or plasma folate in the green or the gray bars. And this was for defining the prevalence of folate deficiency based on risk of megaloblastic anemia. And you can see that
you have 2 minutes.
All right, fell into the likely underestimated or likely correct categories. And if you were to be able to focus on this for long enough, you would see that in general, folate deficiency was greater than 20% in many of the low-income countries and about less than 5% in many of the high-income countries. When we turn to look at this next graph, this time we are looking at the prevalence of folate insufficiency in the countries. And the countries, they're listed on the x-axis and the prevalence is on the y-axis. Again, based on our very crude evaluation, we categorize them as reporting a prevalence that is likely underestimated, likely correct, or cannot interpret. And of note, for most countries, the prevalence of folate insufficiency was over 40%. And we have to say that overall, there's quite limited data for folate status looking at insufficiency. And there are only 11 countries that you're seeing here. So given the diversity of assays used and also the use of non-assay matched cutoffs to define folate deficiency and insufficiency, it's really difficult to interpret these results and to directly compare the status of women within and between countries. We did our best, but we do encourage moving forward the use of microbiological assay in their assessments, and there's some work going on to build up laboratory capacity. Just a very quick mention.
Less than a minute.
Okay, vitamin D status. We just looked at this in a document on nutritional rickets. Again, same, just want to recognize that there's variations between assays and labs. There's variable participation in external quality assurance programs. There's no consensus on cutoffs. And we just put those in tabular form. So I will just conclude with saying that we are learning more and more about some of the key factors that are affecting biomarkers, but there's a delay in the development of global guidance and collection of data in populations. So often more than one biomarker is available per nutrient, and there's sometimes a lack of consistency in the relationship between the two, so we're not able to always use a full data set as well. And there's sometimes a mismatch between the assay used and the recommended cutoff to define deficiency, as in the case of folate. So I feel that there's a need for a more in-depth assessment of the collection, storage, transport of samples, in addition to the selected assay and the methods and the analytics used. And the micronutrients database is attempting to capture this as much as possible, but there's often insufficient details on the methods being reported. And just very lastly, we know that there's a lot of variation within countries. And by focus only on the national prevalence data, we feel that we might be ignoring some of the important population subgroups that may be at increased risk for micronutrient malnutrition, whether that's deficiency or insufficiency. So thank you very much. And I'm passing it all over to Dr. Ashkan.
Okay, thank you very much. Hello, everyone. It's a great pleasure to be here today, and over the next 20 minutes, I'm hoping to provide you with an overview of the process of estimating macronutrient deficiency in the global burden of disease study, and also provide you with an overview of some of the challenges that we have during this process. So in this presentation, I mostly focus on challenges and the methods. All the data are publicly available. If you Google GBD compare, you can access all the data and all the results of the most recent cycle of the global burden of disease study. I would like to also thank the network of GBD collaborators, more than 5,000 people around the world, about more than 600 of them are focusing in the area of malnutrition. So I would like to start with acknowledging the contribution of all people around the world to this collaborative effort. So for any of us who has worked in the area of nutritional risk factor at the population level, we are all familiar with these challenges. Generally, the data availability is a major challenge. Data are limited and scattered. Not all the data is accessible or in the public domain. And data are inconsistent across different countries, within a country, across different sources. There's a lot of data inconsistency. Also, for some nutritional risk factors, there is even lack of consensus in how to define and measure their health effect. So in GBD, like any other risk factor, we use a set of principles to address these challenges. So basically what we do is that we start by systematically identify all relevant data sources from all available sources. We standardize and harmonize the data. We try to estimate the full time series at each round of each cycle of GBD to ensure there is internal consistency. And as new data and as new statistical methods become available, we annually update our estimates. Here you can see a list of various micronutrients for which there is a daily recommended intake. Among all of these, we are in GBD currently estimating 4 of them: iodine deficiency, iron deficiency, vitamin A deficiency, and zinc deficiency. We are aiming to expand our work to others, but data availability is a major challenge. And as we go through the process, you can see how these challenges basically prevent us to generate the best available data. So generally, micronutrient deficiency in GBD can be in the form of a risk factor, disease, and cause. And in this basically presentation, I mostly focused on the risk factor side for 2 of these micronutrient deficiency, vitamin A and zinc, and walk you through the process of estimation of them and some of the challenges. This is a simplified basically flowchart that shows that how we start the process of macronutrient estimation in GBD. So it starts with defining how we define macronutrient deficiency. Then based on that definition, we go through the process of estimating the prevalence of deficiency by age, sex, year, and location. And location in most cases is country. In some countries, highly populous countries, we go down the subnational unit, for example, in India and China, in the state level, in the US, in the state level. And also, another input to this model is the relative risk or the effect size of the deficiency on various outcomes. For example, what is the relative risk of vitamin A deficiency on incidence and mortality from measles? Using the prevalence of deficiency and the effect size, we calculate population attributable fraction or PAF, which represent the proportion of the mortality or deaths that is related to a specific macronutrient deficiency, and by multiplying that to the burden, whether it's a deaths or disability adjusted life years, we calculate the attributable burden. So let's start with the process of defining micronutrient deficiency. And here is the place that a number of challenges actually exist. So when it comes to defining a micronutrient deficiency, we can define micronutrient deficiency as various levels. As low intake of a nutrient, with data come from dietary intake and nutritional survey. It can be defined in terms of biological availability, mostly biomarkers. In some cases, such as iodine deficiency, it can be actually clinical manifestation. It used to be generally over the last 2 decades, in many cases, prevalence of visible goiter has been used, or the deaths from specific micronutrients. And in GBD, mostly because of data availability, we have focused on the definition that we have basically the most available data. For example, in zinc, we use low intake of zinc as a case definition. For vitamin A, we use serum retinol level. For example, iodine deficiency, so far we have used the prevalence of visible goiter as a case definition. And this by itself introduced some challenges. One of the main challenges is that these definitions are not very well correlated to each other. So if you can take a look, you can these data from NHANES, the x-axis shows the rank of an individual in the distribution of dietary intake for vitamin A. And the y-axis shows the rank of the same individual in distribution of the biomarker. And as you see here, there is no correlation actually in the same individual across different individuals in NHANES, and basically between the rank of individual in dietary intake distribution and also in the biomarker distribution. Is this isolated effect for vitamin A? Not necessarily. We did it for a large number of macronutrients. Is another example of zinc. There is no correlation between the rank of individual in the dietary intake and biomarker. So this results in some inconsistency when we have different case definition. Another challenge is that the shape of a distribution is different. Also, as you can see, the cutoff points that is used for defining the distribution is not consistent. Again, data on enhanced distribution of intake and biomarker for male, at young male, 20 to 30 years of age. And as you can see that if we go with the definition of the biomarker, it shows that we have 10% deficiency of vitamin A. If we go with the definition of the zinc, dietary intake of zinc, then you see that we have about 60% definition. Of course, this number is very high, and it's really hard to believe that 60% of the people in the US is basically are zinc deficient based on this definition. So there are a number of challenges. First, this comes from 1 day of dietary recall, and it does not take into account the usual intake. Also, there is an element of measurement error in assessing dietary intake, although it's 24-hour dietary recall, but we know that there's a number of limitations. And also the cutoff point, whether the cutoff points that we have for defining zinc deficiency is very accurate or not. This is another challenge. So, but I just want to give you a picture of the definition matters, and depending on how we use a definition and how we select the cutoff, we see a very wide range of estimates of prevalence of deficiency. This is another important factor that generally what we see, we assume the prevalence of various micronutrients are independent in each other. But this slide actually shows that on the x-axis, you can see the dietary intake of vitamin A, and in the y-axis, you can see the dietary intake of zinc, and colors shows the density. And as you can see, they are very correlated, and the yellow shows the highest density, which means that people who have one sort of deficiency is very likely to have another type of deficiency. And this is the area that we are estimating when we go to the estimating the overall prevalence of deficiency. That creates some complexities. Now let's go to the next step, which is estimating the prevalence of deficiency. When we defined the deficiency, the next step is estimating the prevalence of the deficiency. This is a more detailed workflow. We start on the left with data input, and then we first estimate one of our main covariates, which is, for example, in the case of vitamin A, is a vitamin A supplementation coverage. We generate the full time series of supplementation, and then we use that in another model that estimate the vitamin A deficiency by age, sex, country, year, and we use a number of different covariates, such as basically prevalence of stunting, or an indicator that takes into account socio-demographic index, which takes into account country income, fertility rate, and education, and also a number of other covariates that you can see. So I don't go to the details of this process because it takes a lot of time. I just focus on one of the key challenges that we have here, which is the starting point. If you take a look at the input data, this is the area that we have a number of challenges. So for example, in the case of vitamin A, we use a number of different sources, WHO vitamin and mineral nutrition information system, World Bank database on vitamin A supplementation, and also we started to develop 2 other databases within the GBD that we are starting to use. So this is the WHO database. This is a super useful database that we have been using constantly through the GBD. And this is our main database that we have used so far. As Lisa mentioned, there's a lot of great information here. One of the challenges that we have is that these data, although they are great, they are not super up to date. And we had a chance through the collaboration with WHO, we received the updated data from in April of 2019, but there is room for improvement in terms of the data availability that we see here. As you can see in GBD, we estimate the prevalence in more than 196 countries. And currently the data is available only for 96 of those countries, and majority of countries, we have 1 or 2 data points in the countries. And also, as you can see in the pie chart, majority of these data are before year 2010, and it's really hard to capture the recent trend. For supplementation, we have much more recent data, but again, as you can see here, they are specifically in specific locations, and they only cover 94 countries. Although, as you can see here, there are a number of good data points after year 2010. To address this challenge, we started to, we wanted to use some dietary covariates to inform our model. So in collaboration with UNFAO, we create a global nutrient database. This is a database that provides data on availability, not consumption, availability of various nutrients. And we use them as a covariate to at least give us a good trend when we estimate the prevalence and burden of various micronutrients. And here we have data on availability of more than 150 nutrients from 1980 to the present year. We also started to basically extract data from the GBD database. This is a global health data exchange database, and we identify a large number of records that provide data on both biomarker and intake of various nutrients. And we have started the basic data process, data extraction. Basically for this is a very time-consuming effort. And as you can see here, we have extracted about 33% of the data, and there's a lot more work is going on to improve our data coverage. The last piece of the process is actually estimating the effect size. And this is another area that historically we have used the most recent systematic review that has been published in this area. I just give you an example. For example, in the case of the vitamin A and measles, we started to use basically the most recent systematic Cochrane review that has been published in this topic. But we realized there is a number of challenges which made us to do our own systematic review and meta-analysis. And in the next 2 or 3 minutes, I walk you through this process. This meta-analysis, for example, started to include trials, included 11 trials, and separately estimated the effect size or relative risk for incidence and mortality. One of the challenges or one of the specific things that happens in this meta-analysis, but the author did not use the relative risk that had been reported in by a study. They calculated based on other information that had reported in the study, and that's resulted in differences in the basically pooled effect size. So here you can see what the actual result that we saw in the Cochrane report. Then we went back and re-extracted all the data that were there. Here you can see the characteristics of these studies. Studies from India, Brazil, Nepal, and a number of other countries. And of course, there is a larger study. Everybody is kind of familiar with that large Lancet publication, but there are other studies that also kind of assess this relationship. And then when we went back to the basically compare the relative risk that had reported in the Cochrane report, but with what has already reported in the study. And we see some differences. There are some similarities, but there are also some differences here. And also there are some studies that actually had used seroconversion, not necessarily the outcome of the study was seroconversion, not prevalence of or incidence of measles or mortality from measles. So we started to basically do a range of sensitivity analysis here. And in this sensitivity analysis, what we used, we actually did analysis once based on the actual relative risk that had been reported in the Cochrane review. We did another analysis, only used the relative risk that has reported by the study authors. Then we use a hybrid approach where when the authors had reported the relative risk, we used their result. If they had not reported, we calculated from other information that is in the study. And also we did the study with and without including the seroconversion trials. And here you can see a wide range of sensitivity analysis, depending how we include one column shows the incidence and mortality together without indicator variable, and another one shows a kind of stratified analysis. And across, after comparing all of these and getting expert consultation on various pros and cons, we ended up selecting basically the one that is highlighted 0.72 as a relative risk. But as you can see, depending on the assumptions, the relative risk that can go down to 0.5. And this is a large effect, and this has a major implication when it comes to burden. And here you can see the studies and the distribution of this study. One key factor is that the gamma, which is a factor of between the study heterogeneity, is very large in this in this field. And if we include between study heterogeneity, then almost all of these are become non-significant. So what we are currently using is we are not including between a study heterogeneity, but when it comes to the strength of evidence, we have a lowest, not a very strong evidence here because of the between study heterogeneity that we see. And this is just
2 more minutes, Ashkan.
Thank you. So basically here, we did the same thing for the lower respiratory tract infection and also diarrhea. And you can see for lower respiratory tract infection, in almost all scenarios, the relationship was not significant. And for diarrhea, for most cases, it was not significant, but when we use the hybrid approach, this is a kind of preferred approach, we find it significant, but it's very borderline, 0.97, the upper limit. Then the next step, as we discussed, we go through this process. We have 3 inputs, and then we calculate the population attributable fraction, and we go through the burden estimation. Here you can see the for these 2 risk factors, what is the DALY or disability adjusted life years that is associated with them. And here you can see the ranking of them among all the nutritional risk factor. Vitamin A rank 8, zinc rank 10th. And over the last basically 3 decades, we have seen a declining trend in both of them. Finally, if I just want to kind of summarize a few points here, as you saw in the process, the method of defining micronutrient deficiency has a major implication, both in terms of the prevalence that we see and also the countries that have high and low level of them. Data availability, accessibility, and quality of data is a major barrier. You saw that many of the data that we are using currently are not super up to date. And also there's a significance between the study heterogeneity, the strength of evidence are not basically very plausible, and the evidence that's supporting these relationships are not super strong compared to many other risk factors that we see. And as I mentioned at the beginning of the process, the estimating the burden of micronutrient deficiency is a continuous and iterative process, and we continuously basically get feedback from in different forums, including micronutrient forum and from experts, to basically make sure that we are up to date, both in terms of data sources and the process of estimating the burden of disease related to micronutrient deficiency. Thank you so much. It was a great pleasure. And now I think I welcome my colleague, Dr. Sonia Hurst, to walk us through even more challenges of estimating the burden of micronutrient deficiency.
Hi, good morning, everybody. Afternoon, evening. It is a pleasure to be part of this morning session. And I'm going to continue talking about challenges when estimating the micronutrient deficiencies and related global burden of disease. This is an initiative by the Micronutrient Forum, which has the goal to engage with IHME to advocate on behalf of the micronutrient community. And I would like to thank all experts who are listed on this slide, but in particular, Alex McLean, who was partnering with me on this project and provided his statistical expertise. I would also like to thank Ashkan, Nick Kaspam, and their team members for welcoming us really with a very collaborative spirit. And before getting started, I'd like to declare that my husband is consulting for the Micronutrient Forum. Yeah. So we've just learned a lot about the GBD study that's implemented and led by IHME, and that is published every year in the Lancet. And I just want to put it into a broader perspective than just micronutrients. So the Global Burden of Disease study estimates 286 causes of death, 369 diseases, and injuries and 87 risk factors in 204 countries and territories. So it's a gigantic undertaking, and micronutrients is a small part of that. And they then estimate for each of these outcomes by age and sex and location for the past 30 years. And as Ashkan just really nicely presented, GBD estimates are based on standardized analytical procedures and consider both the prevalence of a disease or a risk factor and then the relative harm that it causes. And they use two approaches. One is the causal attribution approach that is primarily in one of the outcomes, but one of the important outcomes is it's the attributable years lived with disability. And that is used for dietary iron deficiency, iodine deficiency, vitamin A deficiency, and other nutritional deficiencies. And then there's the risk factor approach, which is what Ashkan just presented, is to estimate the attributable death and disability adjusted life years, so the DALYs, for behavioral, environmental, and occupational and metabolic risks. And that is used for iron, zinc, and vitamin A deficiencies. So why do we need information on the prevalence of anemia and micronutrient deficiencies? Well, it is important to know what the disease burden is that these micronutrient deficiencies cause. And this is very important to allow evidence-based advocacy. We, of course, need to know this information to design and deliver effective and safe and sustainable interventions, both to prevent the deficiency, but also to avoid excess intake in other parts of the population. We need the information to monitor the impact of interventions, and as mentioned previously by Lisa, it is important for us to be able to track progress towards the Sustainable Development Goals when it comes to anemia. So what information is needed for accurate estimates? We need a reliable biomarker to define a deficiency of micronutrients of interest. And we need data from nationally representative surveys from different countries and population groups, and ideally per infants, children, adolescents, women, men, and elderly, especially when it comes to the attributable risk. We need access to the data sources and the data sets and adequate scientific evidence from diverse populations to link micronutrient deficiencies with adverse health outcomes. So an example would be iron and anemia, iodine and goiter, zinc and diarrhea, etc. And last but not least, it is important to have adequate documentation of models and assumptions to ensure transparency. So I'd like to talk you through some of these important steps. And I chose zinc as an example, and I chose that because it's only used in one of the models used in the GBD study. So it's only used for the risk factor estimations. And it is a little bit easier than many of the other micronutrients to explain. So in the time that I have. So first we need a biomarker to define a deficiency. And we have plasma zinc. It is not perfect, but it has continuously to be reviewed and recommended by independent expert groups over the past 20 years or 15 years, because it is a fairly reliable biomarker for population status. So I think we're in good shape on that front. Then what about nationally represented data? We have, this is the most recent information in the VMNIS database. And for young children, we have 27 countries that have nationally representative surveys. Some of these surveys repeated, included zinc, like Mexico, Pakistan, and so that's more surveys than countries, but overall we have information only on 13% of countries for young children, and even less for non-pregnant women. So this is just, in my opinion, and I think in everybody else on this panel today, it is not enough to make accurate global estimates for zinc deficiency. And then what about the scientific evidence linking zinc and health outcomes? In the most recent Cochrane review published in 2014, there were 18 randomized studies that met the inclusion criteria and over 200 study participants for preschool and school-age children. Now, not all of these studies have information on health outcomes. Some might just have plasma zinc or growth and were included for those outcomes, but there's still more than 20 randomized controlled studies that provide information. So again, I think there we have a pretty strong scientific evidence linking zinc and health outcomes in young children. So how was zinc deficiency then approached in the GBD study? As Ashkan just presented, the zinc was defined based on dietary intake below 2.5 milligrams of zinc for young children, which is the primary risk group for including the GBD study. This dietary intake is the average EAR, so the average estimated average requirement for young children. And when it comes to national data, the GBD study includes nationally, subnationally representative nutrition surveys, food frequency questionnaires, and FAO supplier utilization accounts and food balance sheets. So for those of you in the audience who are not familiar with the FAO food balance sheets, this is an estimate of food availability. It estimates what food is produced in a country, how much is imported, how much is exported, how much is wasted. And so there's an estimate of how much food is available for the population to consume. And because FAO does that for almost all countries, there is a lot of information available. So there's information on 175 countries. And the GBD recognizes that this is not a very good estimate for dietary intake. So they consider the national nutrition surveys, dietary assessment surveys, as the gold standard, and then use models to sort of correct the bias on what younger children would presumably eat. But one point here is, so this is not dietary intake that is being estimated, but it is inadequate dietary zinc availability. And both from an analysis that I did a few years ago and that what Ashkan just presented, dietary zinc availability is not the same as dietary zinc intake, and that is not the same as zinc deficiency based on plasma zinc concentration. So these do not correlate. And so there's definitely a weakness in that definition. Now, in terms of scientific evidence, Ashkan just presented that they reanalyzed and evaluated the evidence of zinc deficiency as a risk factor for diarrhea and lower respiratory infection using their Mr. Burt model, which is a meta-regression that is good at dealing with data sparsity, and updated the relative risk for diarrhea, and the relative risk for low respiratory infection was no longer significant. Now, one point that I would like to make here is that the scientific evidence is based on zinc supplementation, so randomized controlled trials with zinc supplementation, whereas that is then linked to inadequate dietary zinc availability, and how that is really related to each other is quite uncertain. So now that I spoke or presented how it all works for zinc, I'd like to give you an overview about the other micronutrients that are in the IHNE's GBD study. And I'm going to talk you through how I think the nutrition field defines a micronutrient deficiency and how that compares then to the definition in the GBD study. And when it comes to anemia, there is agreement. Hemoglobin is used below the population cutoff to define anemia. In vitamin A deficiency, there's also agreement. The nutrition field would consider the concentration of retinol or retinol binding protein below the population-based cutoff, and the same is done in GBD. But iron deficiency is actually quite different. In the nutrition field, when thinking about iron deficiency, one would think about concentration of iron status below ferritin, for ferritin below, or for transferrin receptor above the population-specific cutoff. But this is based on anemia, hemoglobin concentration in the GBD study. So the risk exposure is modeled based on hemoglobin concentration below anemia, and then all the different causes that also cause anemia are accounted for in the GBD study. And what is left is divided among 5 other causes, of which iron deficiency is one of them. So it's really a very rough estimate based on anemia. And that iron deficiency definition is used for the risk factor approach. The dietary iron deficiency, that is frankly very confusing when I started reading about this, but there's 2 terminologies. I do understand that now better, because dietary iron deficiency is now used in the causal attribution model and not in the risk factor model. So there's actually that terminology is used for distinction. The dietary iron deficiency in the nutrition field would probably be understood by assuming the data is collected through dietary surveys, ideally 24-hour recalls, and ideally multiple ones, we would have the usual iron intake. But in the GBD study that is done based again on hemoglobin concentration below the anemia cutoff and after accounting for other anemia causes. Now so that would then lead to iron deficiency, an estimate for iron deficiency anemia. But because iron deficiency is caused by multiple other causes, because of the framework that this causal attribution model works, then IGME has to try and identify which other causes also cause iron deficiency and further deduct those, such as hookworm, schistosomiasis, etc., from iron deficiency. So that leads then to an estimate what's called dietary iron deficiency. So quite different from what the nutrition field would understand. And
4 minutes, Sonia.
Great, I think I'm good. Iodine deficiency is in the nutrition field defined on urinary iodine concentration below the cutoff or for thyroglobulin above a cutoff. And in the GBD study that is based on visible goiter, which is only the more severe clinical manifestation of iodine deficiency. So there's a big gap between what the nutrition field thinks of when thinking about micronutrient deficiencies and what's done in the GBD study. And I think it's just important for us to recognize those differences that we can interpret the results accordingly. So in conclusion, to develop accurate prevalence estimates for micronutrient deficiency, we need more information from nationally representative surveys and ideally both for biomarker and dietary intake. And the nutrition field and the GBD study use different criteria to define several micronutrient deficiencies. And my hope is that by working together and generating missing data that we can bring these two definitions closer together. I would like to thank you for your attention, and it is now my pleasure to introduce Dr. Ken Brown.
Good day, and thank you for joining this session. It is very gratifying to see this conference finally taking place, and I want to send a big note of thanks to all of the many people involved in organizing the conference. My name is Ken Brown. I am an emeritus professor at the University of California, Davis. By way of disclosures, I'm a member of the board of the Micronutrient Forum and of the International Zinc Nutrition Consultative Group, iZinc, and I also serve on several expert committees and as a consultant to several nonprofit organizations. You have heard repeatedly from the previous speakers about the dearth of representative data on population micronutrient status and why this information is important for the design and management of public health nutrition programs. The main objective of my presentation will be to describe briefly an initiative being launched by the Micronutrient Forum to address this issue, namely to increase the availability and utilization of reliable information on population micronutrient status globally. But first, I'd like to provide some additional background information. As you have heard, there are several different types of information and sources of information that are useful for managing micronutrient intervention programs, including micronutrient availability in the food supply, dietary intake, biomarkers of micronutrient status and related disease burdens, on program coverage. I want to emphasize that of these, only the micronutrient status biomarkers can be used to define the prevalence of deficiency. This information can be used both to determine the magnitude of the problem and to identify particular subgroups within the population at greatest risk. The specific focus of the micronutrient data generation initiative that I will be describing focuses on the generation of information on population micronutrient status based on nutritional biomarkers. Before discussing the initiative, I want to present an example showing how one country, Guatemala, has used micronutrient status data and other information to justify, plan, and modify over time its intervention programs to control vitamin A deficiency. The first national micronutrient survey in Guatemala was completed in 1965 and found a 26% prevalence of vitamin A deficiency in under 5 children. This finding sparked research on sugar fortification, and the National Sugar Fortification Program was first launched in 1974 and reinitiated definitively in 1987 and continues through the present. Vitamin A supplementation was also initiated in 1990. A follow-up survey in 1995 found that the prevalence of vitamin A deficiency had declined to 16% overall, but remained high in some parts of the country. So both the fortification and supplementation programs were continued, and efforts were made to improve the fortification program by centralizing the site of fortification rather than relying on individual mills. Subsequent surveys have found that the prevalence of deficiency has been consistently less than 2%, even though vitamin A supplementation coverage is fairly low, suggesting that the improvements in vitamin A status are due mainly to sugar fortification. The country has now been able to reduce the scope of vitamin A supplementation so as to reach just infants less than 12 months of age. And the country is also considering reducing the level of vitamin A in sugar because of increasing concerns about possible intakes. In summary, Guatemala is a country that is relatively data rich on this particular issue, and it has used the information to drive policy and program decisions, including concerns related both to vitamin A deficiency and ensuring program safety. It is also worth noting that the scaling back of vitamin A supplementation that was enabled by the presence of information has allowed for some cost savings to the program. Moving from this example, I would like to review the generally less favorable situation globally with regard to data availability. The most extensive repository of information on the prevalence of micronutrient deficiencies is the WHO Vitamin and Mineral Nutrition Information System that Lisa Rogers has just described. Although not all national surveys are represented in the VMNIS, this database does include the vast majority of available information on micronutrient status. This slide shows the number of countries that have contributed representative data for posting on the VMNIS since 1950. As indicated in the summary text box, just 56% of the 138 low and middle income countries have provided information on vitamin A status, and only 38% have provided information on iron status. Fewer still have produced information on folate, zinc, vitamin D, and vitamin B12. Moreover, most countries that do have data have conducted just one survey over this period of time, so much of the information is outdated. To review more recent experience in data generation, iZinc has collected information on countries that have completed surveys over the past 5 years or that are currently planning surveys that include micronutrient status assessment. As shown in this slide, the search identified just 21 countries that completed surveys during this interval or are soon to launch one, or an average of just about 4 surveys completed per year. Of the 20 countries that provided information, it appears that these countries are now assessing a broader array of micronutrients than was previously the case, and they are including markers of inflammation as well to help interpret the results. iZinc also completed a series of interviews with key informants to determine why selected countries did or did not include micronutrient status assessment in their recent nutrition surveys. By far, the most commonly cited barrier to collecting this information was the cost of specimen collection and the related laboratory analyses. Other issues that were mentioned include the lack of awareness of the importance of this information, both among national professionals as well as their advisors in technical assistance agencies. Other factors mentioned were limited access to laboratory facilities and some specific contextual factors, such as the inability to export biological samples or concerns about survey logistics. On the other hand, factors that favored inclusion of micronutrient status assessment were supportive government agencies and local champions who advocated for collecting this information. In addition, the presence of local technical expertise was important, as well as either the existence of ongoing micronutrient deficiency control programs or the desire to initiate programs and the recognition of the importance of data for managing these efforts. To address this set of issues, the Micronutrient Forum has convened a working group to consider how best to overcome the scarcity of information on population micronutrient status. The working group developed a theory of change based on the foregoing sets of information and their vision of what is needed. And they ultimately recommended a multi-component initiative to increase data availability, reliability, and utilization. The strategy development was also informed by a multi-stakeholder advisory committee that involved more than 30 individuals from academia, technical assistance and donor agencies, national ministries of health and research institutions in low and middle income countries, as well as representatives of NGOs in the private sector. The strategy focuses mainly on biomarkers of vitamin A, thiamine, folate, vitamin B12, vitamin D, iodine, iron, and zinc status, as well as markers of inflammation. These nutrients were chosen because of their likely high prevalence of deficiency and the severe health consequences of their deficiencies. The proposed strategy includes several components, which I'll describe briefly. First, a communication effort that includes both advocacy and information dissemination. The main targets of advocacy are decision makers in individual countries, as well as program officers in donor organizations and technical assistance agencies. The key messages focus on the importance of generating and using this information and the steps required to collect the necessary specimens and complete the laboratory analyses, and how the resulting information can support policy formulation and program management. The second component is the provision of technical and financial support to countries to assist with survey design, specimen collection and processing, laboratory analyses, and data analysis and utilization. The third component involves the creation of a small number of regional resource laboratories that are capable of measuring all of the recommended micronutrient status biomarkers and that participate in external quality assessment programs. These laboratories can also serve as regional training hubs to increase laboratory capacity in a greater number of countries. Finally, the strategy addresses the need to expand existing data repositories, ideally to include open access, individual level information on micronutrient status globally. This information should form the basis of periodic updates of the global situation with regard to the prevalence of specific micronutrient deficiencies. This strategy document is now undergoing final editing and should be available on the Micronutrient Forum website within the next month or so. In closing, I want to note that the response to this effort has been uniformly positive, although there are understandable concerns about the cost of the initiative and the ongoing data generation activities. To address this cost issue, I want to present again some results that I showed at the last Micronutrient Forum Global Conference, because I believe the message conveyed by this information is so important.
2 more minutes, Ken.
This table summarizes results of analyses completed by the Minimod team at UC Davis based on data concerning vitamin A status, dietary intake, and vitamin A program costs in Cameroon. At the time of these analyses, the National Vitamin A Deficiency Control Program consisted of several components, including semi-annual vitamin A supplementation and deworming, and vitamin A fortification of commercially produced edible oils. The programs effectively covered 1.28 million under 5 children per year at a total cost of $35 million over 10 years. Based on an optimized program model that was developed using the available data, it was showed that it would be possible to achieve the same level of effective coverage by expanding and strengthening the fortification program while reducing the scope of vitamin A supplementation to focus just on the northern region of the country where vitamin A deficiency was more prevalent and consumption of commercially fortified processed oil was less common. Notably, the optimized program would cost $19 million over 10 years, representing a net savings of more than $16 million. Generating the data that enabled these analyses was not cheap, but the cost of the data collection, lab analyses, and related data analyses and modeling was less than $1 million, which compares very favorably with the potential savings in program costs that could be achieved by applying these results. To summarize, there is currently limited availability of data on population micronutrient status globally, although the situation is changing in several respects. The number of surveys conducted annually is still very low, but the surveys that are being completed tend to include more biomarkers than previously, so they're able to address multiple different micronutrients using a common survey platform. It is clear from multiple settings, of which I presented just a couple of examples, that the availability of data can enhance program coherence and safety and can result in cost savings. I am more optimistic than some of the previous speakers in that I believe there is generally good consensus on the appropriate biomarkers for different micronutrients and the laboratory procedures that should be used to measure them. And there are available repositories of the information. In conclusion, I believe that the time has come to focus on the remaining sets of activities that are needed to close the data gap and to leverage the necessary financial resources and professional support needed to do so. I want to close by recognizing the members of the core working group of the Data Generation Initiative and additional co-authors of the strategy report and all of the members of the Multi-Stakeholder Advisory Committee. And I want to thank all of you for joining this session.
Thank you for the excellent presentations. And now we will start the group discussion. I will ask a question to each of the presenters and then a general question to the 4 of them. It will take around 8 minutes. And then we will have around 12 more minutes to answer the questions from the chat, which there are many, which is great, but we will do our best. First question is for Lisa. Do you have plans to develop estimates of deficiency for any other micronutrients?
Thank you, Rafa. That's a good question. Thank you to all the speakers too. I really enjoyed these presentations, and it is quite motivating to really want to go back to all this data and see what we could do with it. Right now, we've been really focusing on trying to collaborate with our partners and to get as much of the data as possible into our new database that we've been building for quite some time. So with our partners, particularly with IGN, we've been talking about, it's the Iodine Global Network. We've been talking about some of the iodine data and really syncing what they are doing with the iodine scorecard and what we are doing with their database. And so I think that's probably going to be our next project, and looking at some of the iodine deficiency data and trying to write up all the results from these exercises. So I think that will be our next project after we get the anemia estimates completed. But I think otherwise, for the time being, I think we will be more than happy to share the data that we're collecting within the database and to collaborate with partners outside who would like to use this data to develop the estimates. I think that's sort of where we're headed at this time. But thank you.
Thank you, Lisa. Now, next question is for Ashkan. How good are the global burden of disease models to estimate the vitamin A, iron, and iodine deficiencies?
Thanks for the question. So I would say that each model, there are different basically ways to assess the model. Each of these models, for one is based on an input data and also based on the modeling process, and then for the final estimates. I would say that when it comes to the area of basically modeling and a statistical part of the story, we do a lot of cross-validation, out-of-sample cross-validation to make sure that the estimates that we are generating is very close to the data for the countries that we also have data with, and without data, we generate the estimate and we assess the performance. And in that sense, the model works very well. And also there's a lot of data processing. We use various statistical approach, including a lot of machine learning and artificial intelligence in many cases to improve the estimates. In that sense, that's also, I think, very, perhaps we can be very comfortable with what we do there. There are two areas that, as I mentioned throughout the presentation, we are working to continuously improve. One is data. And of course, as we add more data, the numbers will change for the countries that there is no data. And also the area of case definition. So how we want to define whether it's based on intake or based on biomarkers. And we are moving toward the direction that generate estimate for all of these case definition based on dietary intake, based on macronutrient intake, and based on the prevalence of the disease endpoint. And then for different groups that are interested in each of these definitions, they can use that. So that's the direction that we have.
Thank you, Ashkan. Next question is for Sonia. In your fourth conclusion, you state, by working together and generating missing data, we can bring the two definitions closer together. Would you please elaborate a bit more?
Yeah, I think your concern is that they're currently quite different from each other. There's quite a wide gap between the definitions in the nutrition field and the GBD study currently. And I certainly agree that we cannot expect a change overnight or even within next year. But I strongly believe that collaboration is the way forward on all fronts, even if we just sit home and our home offices, and that we will get closer. So I believe that by engaging and providing technical support, the GBD study is very much built on getting expert expertise and listening, hopefully eventually implementing it, we can work closer together. But I also believe on our side, it's important to understand the GBD study better and understand how to interpret the results. And I'm also excited that there's the initiative on generating data. So I think there's multiple fronts that we should work together on. Reason for optimism, definitely.
Thank you, Sonia. Now the question is for Ken. How realistic it is to think that global donors and individual countries will see the increase in the availability and utilization of reliable data on population micronutrient status as a priority?
Well, that remains to be seen. And we hope that the availability of this report will stimulate greater interest in supporting these sets of activities that have been identified. I should mention that a number of representatives of bilateral and international agencies and donor groups were represented in our multi-stakeholder advisory group. And one of the recommendations that they offered was that we need to provide more examples of how countries have actually used the data and how that has contributed to programs. And I included the two examples in today's presentation from Guatemala and Cameroon specifically for that reason, to show how important the data can be, both to justify the need for a program, as well as to course adjust the program over time. I simply don't see how that would be possible without information. And as I noted, despite the high cost of generating the information, the cost efficiencies that could be achieved in implementing the programs in the two examples I provided, at least, more than cover the cost of generating the information.
Thank you, Ken. I have another question, but for the four of you. The question is that the Global Burden of Disease 2019 publication in The Lancet last October, recently, shows a much smaller role of micronutrient deficiencies for vitamin A and zinc. Why is this? So, Sonia, I would like that you address and give your thoughts first, then Lisa, then Ken, and then Ashkan can wrap up the question. And then we will move after this into a few of the many questions in the chat.
Okay, thank you for this question. I think it's specifically true for zinc and vitamin A that were calculated with the risk factor approach, that there's a change in the relevance of those as a cause for disease. And I think also, just for the audience who's not aware of that, but the GBD study continues to be redone. They always add new models, new data, new assumptions. And so each new GBD study supersedes the previous ones. And any changes that are made in this current version would then have a relevance. And so it's not always quite clear to which part of the model changes or data sources have which impact, because there's so much change at the same time. So Ashkan will be better equipped to give us his insight on that front. But I think one aspect that I just want to raise that is related to zinc supplementation is that the lower respiratory infection is no longer significant based on the most recent meta-analysis, which basically reduced the harm that zinc deficiency may cause in the model. And I think that could be partly due to a methodological issue, that when we do a meta-analysis, including all studies that have considered low respiratory infection, then there is no significant impact of zinc supplementation. But when you only consider those that use physician definition, I have to be closer maybe, sorry. When you only consider the clinical definition of low respiratory infection, then zinc supplementation actually does have an impact. So the question is, by just lumping all studies together, do we miss out on an important disease burden in these estimates? So that may be further need fine-tuning and consideration in future GBD studies. I have a few more thoughts, but I want to give everybody a chance to.
Yes, Lisa.
Yeah, thanks. And I've sort of been reflecting on the GBD study too, and I think it's quite complex for for us to dig into, and I think it needs some more thought. But I picked up on the point that Sonia did as well about the lower respiratory tract infections not being included as a health outcome and for zinc as well. But I also am just sort of reflecting on the relativity of micronutrient deficiencies compared to also some of the non-communicable diseases that we're seeing globally as well. And I don't know how much of this relativity comes into play with these studies here. But just thinking about how also we're just really tackling a lot of the non-communicable diseases and what that effect may be, but also reflecting on how we look at micronutrient deficiencies. When we used to really pay a lot of attention to xerophthalmia, to looking at bitter spots and night blind, really looking at some of the severe diseases and goiter. But if you go back to some of the studies that have been done in the last 10 years, that data is not being collected anymore because you need such a large sample size to be picking that up. In which it's great that we are having a less burden of these clinical signs and symptoms of micronutrient deficiency, but also I don't know how much that also plays into the role that these models are picking up too, like were they really relying on looking at severe disease rather than more the subclinical deficiencies and how we have to adjust for that. So those are just some of the bigger range thoughts that I had as well.
Thank you, Ken. Thank you, Lisa. Please, Ken.
Well, and again, there are a number of issues that one can examine. I would like to emphasize what I believe is a fundamental flaw in using dietary data to estimate the prevalence of micronutrient deficiency. Ashkan illustrated the lack of correlation between dietary data and micronutrient status data based on known biomarkers that correlate with defined health outcomes. And given that lack of correlation, the use of dietary data as a proxy for deficiency prevalence is, as I say, fundamentally flawed. Coming back to the example of zinc deficiency, which I believe was Ashkan who presented, showing that the prevalence of deficiency based on dietary data was much lower than the prevalence based on the serum zinc concentration biomarker data, is one obvious reason why the effect of the deficiencies may be underestimated. And the use of food balance sheet data in place of dietary data is worse yet for a whole variety of reasons. So I would look first at that set of issues and again, use that as a point of advocacy for why we need to generate more data on population status. I think the GBD group obviously has done as best they can, given the lack of direct information on micronutrient status. But I think for us as a nutrition community, we need to conclude that it's not good enough. We need to generate the information we need to make these decisions.
Please, Ashkan, wrap up the response.
Okay, thank you. Great points. So maybe I can just quickly respond to 2 points that Ken mentioned. Just 2 clarification there. So one of our challenges in GBD is to make all the stakeholders equally happy or equally unhappy. I just focus on the equal part. And one of the arguments, counter arguments, specifically in the case of zinc to use a biomarker is that how can you reliably basically generate estimate for 196 or 200 countries when you only have data for 15% of them. So data availability is a major challenge. Ideally, our goal is to generate basically, as I mentioned, for all definitions, as long as we have some threshold of data. And that's one of the limiting factors that we have. And just another clarification about the dietary intake for zinc. Our gold standard is 24-hour dietary recall. Of course, that's what we are trying to do. Again, our challenge is dietary recall is not the best, not widely available. So that's why we try to somehow basically crosswalk. We have used different models, including artificial intelligence model that we publish in Lancet Planetary Health, that shows that basically we can generate the model with very high correlation that generate basically intake based on availability. It's not perfect, but as Ken mentioned, this is best what we can do based on the available data. So this is 2 clarifications. Regarding the changes, if I want to kind of categorize them based on the simplified workflow that I showed, compared to previous cycles of GBD, at least in this 2019, the case definition has not changed. The input data has not changed. What we see changes, the first change is that in our modeling framework, we used to use the tool Bayesian hierarchical model. It's called DISMOD, disease modeling software, which was great in terms of getting the age pattern, but it was not super great in terms of getting a time trend. So for that reason, because for many of micronutrient deficiency, we have a great time trend because of supplementation and other efforts, it's important for us to get that right. So for that reason, we switched to another basically modeling framework. It's called a spatio-temporal Gaussian regression model, which borrows information across age, country, and location, and much better fit the data. So when we incorporated that, this helped us to get the trend more accurately. And for that reason, we have a lower burden because of all the great effort that has been done in this area. The second area that we make changes was in terms of relative risk or health effect. So there are three different areas, three different changes here. The first one is that some of the outcome that was in the previous cycle of GBD had been included. In this cycle, it was dropped. The most important one was actually lower respiratory tract infection. The second one is that because of all these new analysis of the data that we had and various sensitivity analysis that we did, the actual relative risk for the outcome that are included, it's actually less protective. As we saw, it used to be, for example, 0.5 for measles and vitamin A deficiency. Now it's 0.7. So the relative risk is less protective. It's another reason for lower burden. And the last one is that in past cycles of GBD, we used to adjust for background prevalence of deficiency. There was this common belief that supplementation and basically is more effective in the countries or in the locations that have much higher prevalence. So we started and we were adjusting the relative risk based on the background deficiency prevalence. Then we started to statistically evaluate that, and we saw that the effect size is almost the same, so it is not affected by the background prevalence. So we are no longer correcting the effect size or relative risk for background prevalence of each deficiency. So that's another reason that we have less protective effects. So all of these together resulted in lower burden for zinc and vitamin A deficiency.
Thank you, Ashkan.
Rafa, can I ask a question of Ashkan about that last point?
30 seconds.
Yeah, so with regard to the issue of vitamin A supplementation, if that is included in the model and the disease burden is reduced, part of that disease burden reduction presumably is due to the presence of these programs. So I just want to caution that the audience should not consider that the reduced disease burden should be an argument for reducing program coverage, which is contributing to that reduction. Am I interpreting that correctly, Ashkan?
Yes, absolutely. So what we are capturing the current prevalence, and one of the factors that contributed to that is actually supplementation. So it has taken that into account. Very great point.
So I need to close the symposium. It's 12:45, but I just wanted to say that to thank everybody. It was an excellent session. Unfortunately, we couldn't go into the many questions that are on the chat. I hope each of you take a look at them, and if you can answer some of them, are key questions there. What I wanted to finish is to say that I see a lot of progress in this key area for micronutrients. So see you at the next session in the Micronutrient Forum Connected. Goodbye.